Good afternoon, everyone. My name is Dominic Akaateba. I work with Ghana Medical Help. Thank you for joining us for today. It's 3 p.m. and so we'll start the webinar. Today we are being led by Dr. Pascal Kangbere. He's a physician specialist and a pulmonary fellow in training at the KBTH Hospital. A few remarks just for you to take note of. You realize that you'll be unable to unmute yourself when you try to. However, the chat box is available. This is so that we don't get distracted through the presentation. But if you do have an urgent question or you have a question that you think you may forget about it at the end of the presentation, kindly make use of the chat box so that at the end of the presentation we can have a discussion around those questions and answers. I just want to thank you once again for joining us for today. And like we always announce, usually Thursdays and Fridays, we'll have this is from 3 p.m. to 4 p.m. Just an hour of your time. And so if you want to learn a thing or two, or you want to lead in a topic or the other, kindly contact me and then we can get this done. This is our own small way of helping to improve practice, especially in rural northern Ghana. So thank you so much. So kindly join me in welcoming Dr. Pascal Kangbere. Dr. Pascal, you have the floor.
Okay, thank you very much, Dr. Akaateba. As you said, my name is Dr. Pascal Kangbere. I'm a respiratory physician in training at Kolebu Teaching Hospital. So today we'll be looking at the asthma, but mainly we'll be focusing on the current management of asthma because there are some lapses across Ghana in terms of how we approach and manage asthma. And hopefully, as we go through this presentation, we'll know what is the ideal and when to treat asthmatic in a certain way versus the ideal way. Okay, so we'll be focusing on mostly adult asthma, so we won't be looking at pediatrics or anything of that sort, and we're looking at chronic management of asthma, not the acute management, since that one hasn't changed throughout time. So we'll start with a basic definition of what asthma is, and you can see highlighted that I highlighted chronic inflammation. And like all chronic diseases, like hypertension, diabetes, once you have it, you have it. You cannot say you've outgrown your hypertension or diabetes, okay? Same way you cannot say you've really outgrown your asthma. There are time and time again, we see a lot of patients that say, I had it when I was a child and now I've outgrown it. There are various factors in which that can happen, but once you've been diagnosed of asthma, you do have the disease. Even if you are not having frequent symptoms, you still have asthma. So there's nothing like it's no longer there. So once you see a patient diagnosed properly, know that they have that condition. It's a chronic condition. It won't go away, but just that they may have infrequent symptoms and therefore they'll think that they don't have the disease. It's a heterogeneous disease which has an interplay between environmental and genetic factors that lead you to developing the disease. And usually this condition is characterized by symptoms, respiratory symptoms, most notably wheezing, shortness of breath, chest tightness, cough that may vary over time and intensity. And it is this variation over time and intensity that makes asthma a bit unique compared to other respiratory diseases, whereby it's kind of more fixed. With asthma, the symptoms can go away on its own or with the use of a short-acting bronchodilators, which we'll look at later on. So these symptoms are not always throughout the day, but the intensity can vary throughout time. So, like I said, it's an interplay between environmental and genetic factors, and it's associated with other allergic conditions such as food allergy, allergic rhinitis, etc. And it's usually there's a high prevalence in developing countries than in developed countries than in developing countries. And there are many risk factors that can predispose someone to developing asthma. One is if you have a family history, and then maternal smoking during pregnancy. So if your mother was exposed to environmental smoke or she was smoking during pregnancy, it can lead to the offspring developing asthma with time. And then reduced childhood infections. Won't go too much into details, but this is referred to as a clean hygiene theory, which explain why if you're not exposed to a lot of infection or you live in a too clean of an environment, you may you're at a higher risk of developing asthma than someone who has been exposed to some childhood infection and their environment isn't overly clean. We said it's associated with atopic conditions like other allergic conditions. So if you have atopy, you may have a risk of developing asthma. Obesity and premature birth are all also risk factors for developing asthma. And these are some of the things you should look out for when you're taking a history of someone who has asthma. We all know some of the common triggers for asthma: dust and pollen, infection. So you can have a pneumonia that can precipitate your acute asthmatic attack. Animals and pets is something sometimes we don't really ask about. Cats, etc., are all animals that can lead or precipitate your asthmatic attack because of the antigens they may have on their fares. Exposure to smoke can also lead to you developing a acute exacerbation, exercise and stress, and certain hormones, especially in females, when there's certain surges of some hormones like progesterone and estrogen can lead them to developing an acute asthmatic attack. Now, it is always important that when you have a patient who is an asthmatic, you have to classify them, okay? And this classification is important because it kind of determines or kind of informs how you're going to start the treatment and where you're starting the treatment for. So if you're looking at the classification of chronic asthma, this is how we classify it. We can classify as intermittent. So it means that you don't have very frequent symptoms. So you have it like once a month, in very infrequent, not every day of the week. Then you can have a persistent form of asthma, okay, where you have it more frequently, either once or twice or 3 times a week, you're having symptoms of asthma. Okay, so you can divide the persistent into mild, moderate, or severe. And this division is usually based on your symptoms here, how frequent you're having your symptoms that you can see here, or you're having your nocturnal symptoms as well. So it's always good that when you diagnose someone with asthma, you kind of find out the frequency of their symptoms so that you can either classify them as mild, moderate, or severe persistent, or whether they have intermittent asthma. And these are some of the things you should look out for in terms of trying to determine what their severity is. And this is just a summary of the previous slides where you have the intermittent, mild, persistent, moderate, and severe, and then the symptoms that is associated with those classification, and then how frequent their nocturnal symptoms are. Okay, so you can have the nocturnal symptoms, and then if you're using the lung function, it also helps you determine the severity of the disease. Now, why this severity is important is, as I said, it helps you know where you're starting from. And we know that with asthma, we usually use the GINA guidelines to kind of determine how we are going to manage the patient. And we know that the GINA guidelines, you usually have the step 1, step 2, step 3, and step 4, and step 5. So once you've classified the patient as to mild, persistent, moderate, severe, or intermittent, it helps you know which step you are going to start from. So if you're on intermittent, you are really going to start your treatment from step 1 based on the GINA guidelines. But if they have a persistent type of asthma, or you classify them as persistent asthma, whether mild, you are going to start at step 2. If it's moderate, you're really going to start at step 3. But if it's severe, you're either going to start at step 4 or step 5. So it's always good to classify your patient based on their symptoms in terms of the severity, to know where in the GINA guidelines you are going to start from and which doses of your medications you are going to use. You don't have to memorize this. You can easily pull it up from the internet, from Google. Now, by way of pathophysiology, we won't delve too much into this because there's a lot to cover. But by way of pathophysiology, we know that asthma is usually mainly driven by bronchoconstriction and airway inflammation. And we know that usually when you're exposed to an antigen, the first thing that's going to happen is you're going to get sensitization of that antigen. So an antigen will enter your airways. It will be picked up by antigen presenting cells that will send this antigen to your lymph nodes, whereby there will be activation of T helper 2 cells, which will then produce interleukins, that will down stimulate B cells. And then these B cells will produce IgE antibodies, and these IgEs will bind to mast cells. And this process is known as sensitization. When this happens, you don't really have an acute attack. It is now when you are re-exposed to that same antigen that there's now cross-linking of the IgE antibodies. And these cross-linking of the IgE antibodies is going to cause what we call mast cell degranulations. And when these mast cell degranulates, they are going to release histamine, prostaglandins, and leukotrienes. And these are all inflammatory mediators that will lead to your bronchoconstriction, and that will give you your symptoms of asthma. Now, note that this is a type 1 hypersensitivity reaction, and it's not just only these inflammatory markers. You also have other factors like goblet self hypertrophy that will produce a lot of mucus that will now occlude the airway, and then you have narrowing of your airway. And then you also have smooth muscle hypertrophy, which will also cause intense bronchoconstriction. And these happen simultaneously. That leads to the narrowing of your airways, and that will lead to your symptoms of difficulty breathing, your wheezing, your chest tightness, and sometimes your cough because you have a lot of mucus in the airway. You are trying to get it out of your system by coughing it out. And then you have the inflammation. And so it's basically the inflammation and the inflammatory mediators that is driving your bronchoconstriction, and your bronchoconstriction is what is leading to your asthma symptoms. So to summarize, basically, when you're thinking about the pathophysiology of asthma, you should really think about bronchoconstriction and inflammation. And it's usually the inflammation that is driving your bronchoconstriction, because as you're having worse or more inflammation, you're going to have more bronchoconstriction. So once you're able to tackle your inflammation with time, you're not going to get frequent bronchoconstriction, and your symptoms will improve. But in the situation whereby you have bronchoconstriction, you want to give something that will open up the airway, because the airway is now narrow. So you want something to dilate the airways. And that's when we use your beta agonists such as salbutamol, etc., to kind of open up the airways, while you give something to kind of tackle the inflammation so that you don't have worsening of your bronchoconstriction or prolongment of your symptoms. Now, these are some of the medications that you can be used to treat asthma, but I like this table because it kind of groups them into bronchodilators, so things that would tackle the bronchoconstriction. So you have your sympathomimetics, and those are usually your short-acting beta agonists. So most popular is your salbutamol that we use a lot is in the form of Ventolin, but you also have albuterol. But then you also have salmeterol and then formoterol, and we'll come to these two drugs later because they play a very important role in the management of asthma, especially in our settings. And then you have the ones that will tackle the inflammation, usually prednisolone, hydrocortisone. Those are usually steroids, and we know that steroids is an anti-inflammatory drug. So usually the drugs that caters for your inflammation is usually your steroids, your corticosteroids, while your bronchodilators usually will cater for the bronchoconstriction that is happening. We have other forms of targeted therapy that are the anti-IgE antibodies, and this one you're thinking when you're getting towards group 5, step 5 in your GINA guidelines or steps of your management. Now, further, like we said, these are the drugs, the various classes of drugs that are available in the treatment of asthma. So the most common you will see is what we call SABA. So when we say SABA, it just means that it stands for short-acting beta agonist. So when we say SABA, we mean short-acting beta agonist, as you can see in this small writing. And as we said, albuterol is one, but you also have Ventolin as well, which is a Ventolin inhaler, which is salbutamol. So your salbutamol inhaler is a short-acting beta agonist. So when they say SABA, we are referring to those class of drugs. We also have LABAs, which is long-acting beta agonist, okay, usual beta 2 agonist, okay, and we have various forms. Salmeterol is one. We also have formoterol, which is another long-acting beta agonist. So when you're reading the steps, you will see SABA, LABA, You also have ICS. ICS stands for inhaled corticosteroid, and as the name will suggest, it's an inhaled corticosteroid, so it contains steroids. And we know that the steroids are usually used to treat the inflammatory component of asthma, while your LABA and your SABA are bronchodilators, and they will sort out the bronchoconstriction. So you have various ICSs. Most popularly known in Ghana, we have the budesonide or Pulmicort that is usually nebulized in terms of acute asthmatic attacks. Then we have the ICS LABA. So as the name suggests, it's a combination of your inhaled corticosteroid plus your long-acting beta agonist. So it's a combined medication. So that means the inhaler or the drug or your inhaler contains an inhaled corticosteroid and a long-acting beta agonist in one canister. So mostly, Symbicort, which is very popular and is widely used, and that is nowadays sometimes the go-to inhaler that we write for most of our asthmatics once we diagnose them. The other ones you see is fluticasone, salmeterol, that we see in various forms such as Seretide, and we'll have a look at some of the drugs that are available in Ghana. Note that even though we have these classes for the treatment of asthma, we do not have most of them in our parts of the world. We have SABA and we have ICS LABA. Hardly do we have only ICS and only LABA. So for us, we usually have the ICS LABA combination and then the SABA only, but not individual LABA and individual ICS. It usually comes as a combined inhaler. So again, if you look at the steps, which we'll look at shortly, they'll always mention that high dose, low dose ICS or medium dose ICS. So this is some of the various ICSs, that's inhaled corticosteroids, and what constitute as low, medium, and high dose. So for people older than 12, when you say you are using budesonide, okay, which is you can find it in Symbicort, once you are doing low dose, you are looking at 200 to 400 micrograms. And then if you are increasing the dose to medium dose, you are looking between 400 to 800. And high dose is considered as more than 800 micrograms. Okay, so it just helps you know that when you're going up the steps in terms of your management, and you see medium dose, you can just refer back and see what constitutes as what dose of your inhaler constitute as medium or high dose, so that you know where you are. And this is just for children. You can see that the doses are different. 200, 400 was initially low dose in adults, but this will be considered as medium dose in children. So always take note of the population in which you are giving your medications. Pediatricians are not too happy with us giving a lot of steroids to children, okay, for various reasons, because it can impair the growth plate and then cause some growth retardation. So always be careful and be cautious in the pediatric population when you're giving them steroids. Now, we'll move to the management of asthma. Now, for you to really grasp the management of asthma, you really need to understand two important definitions or two important terminologies. And these terminologies, you come across them when you are referring to treatment of asthma in whatever guidelines you are using. And it is controller medication, which is also known as preventer medication. And you have a reliever, which is also known as a rescue medication. Just depends on which text you use. Some use controller, some use preventer, some use reliever, some use rescue. So it's virtually the same thing, just that the terminologies are different. Now, a controller medication is usually used every single day. So you have an inhaler, let's say inhaler A. Okay, let's say inhaler C. So C for controller. So you have inhaler C. Okay, and you use it every single day. So you use it when you wake up, you use it in the morning, then you use it in the evening. Next day, use it in the morning, in the evening. And the purpose of the controller medication or the preventer medication is that it's supposed to prevent you from having an asthmatic attack, hence the name preventer. It's supposed to control the inflammation in your lungs, as we saw in the pathophysiology, it's the inflammation that is driving the bronchoconstriction. So it's supposed to reduce the inflammation in the lungs and prevent you from getting an asthmatic attack. So use the controller medications every day to prevent you from getting an asthmatic attack. Okay, and because it's dealing with the inflammation, it's controlling the inflammation, it is usually a steroid-based inhaler. So the steroid-based inhaler, it really acts as a controller to prevent your symptoms. Now you have what we call a reliever medication or a rescue medication. Now these are inhalers that you use. So let's say inhaler R, okay, is that when you are using the controller medication, okay, so use controller inhaler C for controller in the morning and use it in the evening. Now, if you use it in the morning and for one reason or another, you are having symptoms or you're developing an acute asthmatic attack, now you use inhaler R rescuer to rescue you or to relieve you of your symptoms, hence the names. So because we said the symptoms are usually caused by bronchoconstriction, which is usually driven by the inflammation. So once you're having the bronchoconstriction, you want to open up the airways so that you have more air moving in and out of your lung so that you be relieved of your symptoms or you be rescued from your symptoms. So the reliever medications are usually bronchodilators. So they open up the airways. So you have controller medications, which reduces the inflammations and prevents you from having an acute asthmatic attack. And then in case you do have the asthmatic attack, you use your reliever medication to give you relief from your symptoms. And then you continue with your controller medications. And that is the strategy in which we used to use in terms of managing asthma patients. So we have a controller medication and a reliever medication. Now, in the olden days, in the yesteryears, this was how we approached the management of asthma. So this is the older strategies which we used to manage asthmatic patients, but it had a lot of problems. Okay, so as you can see from what is circled here, okay, you can see that preferred controller choice. So these here, you're looking at it in this direction. So if you're in step 1, step 2, step 3, step 4, step 5, this is what you use as a controller medication. So these controlled your inflammation, reduce the inflammation so that you did not get an asthmatic attack. So you had low dose ICS, and we said the controllers are usually steroid-based. So you have low dose ICS, inhaled corticosteroid. Then you have, if you are at step 3, you're going to have a low dose inhaled corticosteroids with a long-acting beta agonist. So it's an ICS LABA. And then step 4 is medium dose to high dose. And we saw in the previous slides what constitute medium dose, high dose. And it just depends on what drug you are using as your inhaled corticosteroid. So use these as your controller medications. Now, for whatever reason that if you are using these and you had an acute asthmatic attack, then you use your short-acting beta agonist. The beta agonist will open up the airways, and then you get air moving in and out, and therefore you get control of your symptoms, relief of your symptoms. So you had a short-acting beta agonist. So that's your Ventolin, okay? And then when you got to step 3, 4, 5, you were using either the Ventolin or you were using a low-dose inhaled corticosteroid / formoterol. And we'll come to this later. So this is what you are using as your reliever medication. But if you notice that in step 1, you don't have anything as for controller. It's only when you get to step 2 that you are using an ICS as a controller. So in step 1, once you were having symptoms, you just use your short-acting beta agonist. That was it in the olden days. And this kind of created problems down the line. This approach that we used to use or still use it to some degree causes a lot of problems for both the clinician and the patient. Why? The problems that, and these were other controller medications that you could use in case you didn't have any of these available. You can use these as well or add them on. Now, the problem was that it caused what we call SABA overuse or reliance. So people depended so much on their salbutamol inhalers. Because if you were in step 1 and you weren't using a controller, you only use a short-acting beta agonist anytime you have symptoms. once you moved up the steps, you become too used to the salbutamol inhaler. Okay, so once you've gotten to step 2, you have used salbutamol for a long time on step 1, then step 2, you use it step 3, and so forth. And the problem is that because salbutamol acts very quickly and opens the airways, people get relief and their symptoms are okay. Steroids take a bit of time to work. Okay, so people tend to get more relief using the salbutamol inhalers. But the salbutamol inhalers does not really fix the problem of inflammation. It's the steroids that does. So people use the salbutamol anytime they were having symptoms and we're not using their controller medication, their steroids, because I mean, I'm having difficulty breathing. I use my salbutamol, I'm better. Why should I use another inhaler, which wouldn't really give me relief? So anytime they were having symptoms, they just depended on only the salbutamol inhaler and didn't really use any anti-inflammatory inhalers. And that led to them thinking that salbutamol is better than anything. So anytime I'm having my attack, I'll use salbutamol, forget the other inhalers. The problem is that also some people have 2 inhalers, one for the controller, one for the reliever. And the problem is that you may get confused. Okay, which one am I using for the reliever? Which one am I using as a controller? And sometimes some patients mix them up. What they should use as a reliever, they use as a controller. And what they should use as a controller, they end up using as a reliever. So it caused a lot of problems. So these were the problems that we faced in the previous strategies in terms of managing asthma. But the question is, so what's the problem if we use salbutamol inhaler and once in a while we use the steroid inhaler to treat the inflammation? Well, we now know that the more salbutamol you use, the worse your outcomes are in asthma. I'll repeat that again. The more salbutamol you use, the worse outcomes you have. And this is because once you use the salbutamol or your SABA a lot, your body gets used to the drugs. The beta-2 receptors in your lungs get used to the drug. They get desensitized to the drug. So with time, the drug does not become effective as it used to. So as you use it more and more, your body gets used to it. The receptors don't respond to the drug now. And therefore, now you start having worsening of your symptoms, more frequent exacerbations, and worsening of your lung function. And this has been seen in many studies. Won't bore you with that. But it's just for you to know that the more your patient uses salbutamol, Ventolin alone, with time, this Ventolin is not going to be effective for the reasons I've mentioned. And therefore, their symptoms will become worse and they'll have more symptoms. And then their lung function is going to go down because you are not still addressing the inflammation, and then the body receptors are desensitized to the beta-2 agonists. And this, like I said, has been shown. So, but again, why is that issue? Now, this study, again, I'm going into depth, is just to highlight the problem. Just looked at the number of, this was recently done a few years ago, published a few years ago, and it looked at how many Ventolin canisters. So you use one, how many you use, and what are your outcomes in patients. So they looked at how many prescriptions. So in a year, if you are using 3, 4, 5 canisters of Ventolin, what are the outcomes that asthmatics had? And they did it in various countries, okay? Some African countries like South Africa, Egypt, and Kenya was involved. And what they realized is that, again, the more salbutamol canisters you use in a year, the worse your outcomes. Okay, so we don't want patients using too much of the salbutamol inhalers or your Ventolin inhalers. Okay, so what they found out is that irrespective of what step you are on, okay, so if you're on step 1, step 2, step 3, step 4, if you use more than 3 canisters, whether you are in step 1, 2, 3, or 4, your risk of having an exacerbation increases almost by 50%. So that means the more canisters you use in a year, and this isn't 3 canisters in 1 month, in 2 months, or in 3 months, it's 1 year. So 1 year. Okay, so let that sink in. So if you use 3 Ventolin canisters in 1 year, so maybe use one every 4 months, that's 3 in 1 year, your risk of having another exacerbation increases by almost 50%, especially if you're in step 4. So the more you use, the more likelihood your body is going to get used to it, desensitize the receptors, and then now you have worsening symptoms. And then when it comes to mortality, again, this is in 1 year. If you use your risk of dying using, this was looking at the risk of dying, increases if you are using 3 to 5 canisters in 1 year. If you are using more than 11 canisters in 1 year, that means you use 1 canister in January, 1 canister in February, 1 canister in May, April, or one a month. You know, there are 12 months. So if you use 1 a month, you are using about 12. Your risk of dying is more than 2 times. So you have a 2 times risk of dying if you are using even 1 canister every month for 1 year. So that shows you that the more salbutamol you are using and the more you're getting desensitized, the worse your lung function, the higher your risk of patients are going to die. And I can assure you that many people, when we see an asthmatic, we say, oh, how are you? I'm fine. Any symptoms? No. We don't even ask how many canisters they are using. Sometimes you'll say, oh, this month I used 2. Or in the past 3 months, I used 3 canisters. So if they're using 3 canisters every 3 months, that means in a year they use 12. That means the risk of dying is more than twice, 2 times. It has increased by 2 times. So you have to be very vigilant. And that shows that you should be asking your patients to be using more of the inhaled corticosteroid medication or inhalers so that they don't get the bronchoconstriction at all for them to even need the salbutamol inhalers. So this just showed that in the African countries, how many % of the patients that they saw were using more than 3 and more than 10 canisters. So again, salbutamol just sorts out the bronchoconstriction, but it doesn't sort out the inflammation. It's the inflammation that is sorting out the bronchoconstriction. So the salbutamol does not deal with the underlying problem, which is the inflammation. It's the steroids that do that. So when you are seeing an asthmatic, don't just write salbutamol, or don't be okay that they are using 3 canisters in 2 months. Say, oh, your symptoms are controlled. Continue. It shows that you really need to intensify your treatment and your steroid use in these patients. So now the way forward from what we've learned previously is that we are now doing what is called as SMART therapy. And that SMART just means single, maintenance, and reliever therapy. Unlike before, whereby you had inhaler C as a controller they use morning and evening, and then you have a different inhaler R, which is a reliever that you use in case that when you use inhaler C and you're having symptoms, you use inhaler R. So you tend to have 2 different inhalers. So now we are advocating that you use only 1 inhaler as a controller and the same inhaler as a reliever. So you use inhaler, let's say S for SMART. So use inhaler S morning and evening, morning and evening. And when you are having symptoms, then you still use inhaler S to relieve you of your symptoms. So you use inhaler S to curtail the inflammation. And when you're having symptoms, you use inhaler S to open up your airway, so for bronchodilation. So that is now the way we want to treat asthma patients. So now they only have 1 inhaler. We are trying to avoid them getting 2 inhalers, okay? So 1 inhaler that will act as a controller and the same inhaler that acts as a reliever. And because why we are doing this is that we don't want patients to be too reliant on the salbutamol Ventolin, because it does not tackle the underlying inflammation, which is what is associated with increased symptoms. So by adding an inhaled corticosteroid, okay, to your rescue or your reliever medication, so when you're having the inflammation or the acute asthmatic attack, it's because of the inflammation. So once you give a reliever and you add an anti-inflammatory steroid, it's going to tackle both the inflammation and also give you bronchodilation. So this is why we want to go more with the SMART therapy. And we are trying to use 1 inhaler to use for both a controller and as a reliever. And because of these problems that we had in the past, GINA, as of 2019, said that you should never use a short-acting beta agonist or dilator, bronchodilator alone. Okay, it's not longer recommended. So that means never just give only Ventolin, okay, or never give only salbutamol. You have to give a steroid. You never now no longer that salbutamol alone. And if you remember in the old approach, step 1, you only use salbutamol when you are in step 1. There was no controller. Now that is no longer the thing. So the new or the now recommended way of treating asthma or managing asthma is as follows. So we divide them into either track 1, okay, that's here. So you have track 1, that's this group, or you have track 2, that's this group, okay? Now, worldwide, irrespective of where you are going to practice, UK, America, if you Japan, wherever you want to go, this is the preferred way of managing asthma, track 1. And this is the smart therapy approach. So this is the smart therapy whereby you're using one single inhaler for your controller and the same inhaler as your reliever. So just looking at these two steps, so this one and this one, you'll notice a few things. So you'll notice that in the smart therapy, step 1 and step 2 are combined. Okay, in the track 2, there are 2 separate entities. Okay, so how you manage step 1 is different from step 2, but in the smart approach, how you manage step 1 is the same as step 2. Okay, and then you also notice that the reliever medication that's down here is here as a needed ICS formoterol. Okay, and you can see in the step 1 and 2, you have low dose ICS formoterol, maintenance, low dose maintenance ICS formoterol, medium dose maintenance ICS formoterol. So you're using ICS formoterol as your controller. And when you're having symptoms, you are still using the same ICS formoterol as your reliever. Converse to the other track, that's track 2, you see ICS whenever SABA is taken. They just said ICS whenever SABA is taken. Here's ICS formoterol. So anytime you give salbutamol, you have to give an inhaled corticosteroids because no longer are we doing SABA alone. Then you have the low dose ICS, that's the inhaled corticosteroids as your controller to control the inflammation. And when you have symptoms, you are going to use your ICS SABA as and when, or your only salbutamol inhaler. So you're going to use your inhaled corticosteroids. When you're having symptoms, you use salbutamol. Step 3, you're using inhaled corticosteroids with a long-acting beta agonist in step 3 and 4. And when you're having symptoms, you're using a short beta agonist. Now, these are currently the inhalers that are available in Ghana, okay? In Ghana. So we usually classify inhalers as dry powder inhaler or the pressure meter dose inhalers. This one just shoot out a dry powder. This one gives more of an aerosolized, the medication in an aerosolized form. So your Ventolin, salbutamol. So anything that is inhaler that's like Ventolin or salbutamol is usually a PMDI or pressure meter dose inhaler, while the other types are usually the dry powder inhalers. So we have Seretide, which is fluticasone, salmeterol. Fluticasone, salmeterol. So the fluticasone is your ICS, salmeterol is your LABA. So this ICS LABA. Fluticasone is the inhaled corticosteroid, and then the LABA component is your salmeterol. And we have the almighty Symbicort, which is budesonide, which is the ICS or the steroid component, and then your formoterol, which is your long-acting beta agonist, okay? And then if you're having the ones that looks like Ventolin, we know Ventolin, you have Fortide, and this one came into market a couple of months ago. And then you have you also have Serocot, okay, that's also fluticasone, salmeterol. So it's like this is the DPI of this formulation. So Seretide, this is the Ventolin form of it, same medication. And then the PMDI, that's Symbicort, the same medication in terms of the way you can deliver the medication, like Ventolin is like budesonide in the form of Fortide. So you have these inhalers available that you can use to treat your asthmatic, okay? So So if you go back to track 1, you can see that they say ICS, low dose ICS formoterol. ICS formoterol. So your inhaled corticosteroid and formoterol. They did not say, again, they did not say ICS LABA. They said ICS formoterol, not ICS LABA. So it means that for you to do track 1, that is smart therapy, your inhaler should contain formoterol. That means your long-acting beta agonist should be formoterol. That means if your inhaler does not contain formoterol, you have no business using it as smart therapy. You go to track 2. If your inhaler does not have formoterol, you cannot use it for track 1. You cannot use it as smart therapy. And they are specific. You see ICS formoterol, ICS formoterol, even reliever ICS formoterol. Formoterol is a long-acting beta agonist. Okay, so when you're having an acute exacerbation of your asthma, your bronchoconstriction, you want something to open up your airways very quickly so that you can breathe. You don't want to give something that is going to take a long time to act. Okay, and that is why Ventolin is very popular, because onset of action is very quick. A few minutes, you open up your airways. So you want a medication, the bronchodilator component, to have a quick onset of action. Now, formoterol is a long-acting beta agonist. But although it is a long-acting beta agonist, although it's a long-acting beta agonist, a LABA, its onset of action is as quick as salbutamol. So formoterol is the only currently formoterol is the only long-acting beta agonist that kicks in as quick as salbutamol. Okay, so it's the only LABA that its onset of action is as quick as salbutamol, and that is why you can use it for smart therapy. So that when you are using it as your controller, you're getting the steroid part to sort out the inflammation. And then when you seem to have symptoms or an acute exacerbation, you use it, and the formoterol component, which acts very quickly, will cause your bronchodilation, and then you have relief of your symptoms. So again, if you are using an inhaler and it does not contain formoterol as its long-acting component, you cannot use it for track 1. So in track 1, you use this morning, evening, morning, evening, morning, evening. If you have symptoms, you use the same inhaler. All right. So that means currently in Ghana, you can only use Symbicort and Fortide as for track 1. You cannot use Seretide as track 1 because we said what? Seretide is salmeterol. It's not formoterol. So salmeterol does not have that rapid onset of action like salbutamol. So if you give this when they're having an acute asthmatic attack, it'll take them an hour before they have the bronchodilation. And it won't be nice for someone to wait 1 hour before they have relief of their symptoms. So that means that currently you can only use Symbicort and Fortide for track 1. That means if you prescribe Symbicort and they are using it PRN, morning, evening, 2 puffs in the morning, 2 puffs in the evening, you do not need to add Ventolin. You just tell them that when they're having symptoms, use the same Symbicort to relieve your symptoms. Same with Fortide. So once you're using these, it's not necessary to add Ventolin or Ventolin inhaler. You will tend to see that people will have Symbicort inhaler and also still have Ventolin inhaler, and you say that, okay, use Symbicort. And when you're having symptoms, use the Ventolin. No. If you are giving them Symbicort, you are doing track 1. Okay. We won't go into comparison of this thing. And these are just the track 1. If you are on step 3, the number of inhalation you can take. So if you are in track 3, the ICS formoterol, 1 inhalation once or twice a day, and 1 as needed. So this is the maintenance, 1 inhalation morning and evening. And then if they're having symptoms, they take 1 inhalation to relieve them of their symptoms. If you're on step 4, it's 2 inhalation twice a day. So 2 puffs in the morning, 2 puffs in the evening. And when they're having symptoms, you can do 1 puff or 2 puffs. But you'll notice that anytime anybody diagnosed asthma, automatically they jump into 2 puffs BD. Everybody gets 2 puffs BD, no matter when you're diagnosed, because nobody assesses the severity to see whether they're in step 3 or even step 1 or 2. In step 1 and 2, it's just as and when PRN and when you're getting your symptoms. So just it's always important to assess and know where you're starting from. These are just to guide you with your symptoms or how often you should be giving the inhalation, okay? So if you're on step 3, we saw that in the previous slide, 2 inhalations a day or whatever, depending on what you are using, okay, or what inhaler you are using. So now when you come to track 2, so track 2 is similar to the old approach. You have 1 inhaler for your controller, and when you're having symptoms, you use a different inhaler to relieve you of your symptoms. So this is what you're using, and here you see ICS LABA. You don't see ICS formoterol, ICS LABA. Like I said, we don't really have only ICS inhalers, okay? So most often we'll just give, if you're on seretide, we'll use it throughout, ICS LABA throughout here, okay? Because we don't have only ICS inhalers. So once we are giving an ICS LABA as a controller and then you have symptoms, we are going to give you salbutamol. So if you have seretide, which is not formoterol, it's fluticasone salmeterol, you give it 1 in the morning, 1 in the evening. If they're having symptoms, you use salbutamol. But if you're having Symbicort, which is ICS formoterol, you give it 1 in the morning, 1 in the evening, and when they're having symptoms, you use Symbicort again. So this is how track 2 looks like. We've gone through it. And again, that means seretide, you are using track 2. Symbicort, you are using track 1. Serocort, you are using track 2. Fortide, you are using track 1. So it just depends on which inhaler you have. That will determine how you're going to approach the management and what you're going to do. So basically, just to summarize, take home, important thing is don't give only salbutamol inhaler to anybody with asthma. Always combine it with an inhaled corticosteroid. Try and avoid people using too much of your salbutamol. As we saw the detrimental effects of using only salbutamol and relying on it alone, you are going to increase mortality and risk of exacerbation. And then know which inhaler you can use for smart therapy and which one you have to use for track 2. All right, so I'll end here. Thank you.
All right, fantastic. Thank you so much. This has been great. I'm sure most of us have learned a thing or two, and it's going to help inform practice. So we have about 12 minutes to 4, and so we would take questions. If you have any question, kindly electronically put up your hand, and then I can unmute you to ask your question. So whilst probably wait for those, I will go with the first one. Dr. Pascal, most of us in rural practice, especially physicians, will typically find that people still use things that are what I call in red. Like you find a patient coming to the consulting room with salbutamol tablets. I can imagine you laugh. Others would also come with asthma or asthma drain. Exactly. What's your caution to prescribers with the use of that, so that then we can demystify the half truths that the drug companies usually go into rural areas to tell people and misinform and misguide people.
Okay, so again, right now, salbutamol tablets is not supposed to be used. It's been phased out because it's associated with a lot of mortality, and people tend to use the salbutamol tablet a lot. But we've seen that you really need, what the backbone of managing your asthmatic is steroids. Okay, that forms the backbone of managing your this thing. So Asthmadrin, salbutamol tablets, we no longer use them. They shouldn't be used. They are just causing more harm to your patients than good. What they need are the inhalers. And then you should find out what inhalers is available in your encampment. sometimes it's only Seretide. And you know that if you're using Seretide, they need a salbutamol as a reliever and use the Seretide as a controller. If you're fortunate to have Symbicort, you can do the preferred track, that's track 1. You use the same Symbicort as a controller and use your Symbicort as a reliever. But Asthma-Dren, salbutamol tablet, they are no longer in use. Nobody uses them again. They've been phased out because they cause more harm than good.
Great, excellent. So anyone with any question, kindly put up your hand and then we can unmute you to go ahead. I don't see any hand up. I guess you did an excellent job. Either we are 100% okay and happy with our questions, or hopefully we are not confused. So there are a couple of questions in the chat box. Maybe I can read those out since we don't have people's hands up. Please don't feel shy. Just put up your hand if you have any question, any discussion, anything to say, really. So the first one from Nicola Oko says that, Doctor, kindly elaborate on the reduce infection in childhood. That's those residing in too clean environment. Since you mentioned dust and pollen part of the triggers. Pascal, you want to take it question by question? I should just read maybe about 3 or 4 of them and then.
Okay, if you read this and I'll try, maybe some of them will be interrelated. So one is looking at the
looking at exactly the triggers and then reducing the infection. The second one, okay, so Dr. Ose says, please share the slides. Yes, I'll share the link so that you can have the recording of this and the slides. I would shortly share that in the chat box. Then MFR asks, is there an advantage of the PMDI over the powdered preparations? So the second one is advantage of the metered dose inhaler over the powdered ones. The third question is, can one get asthmatic attacks without the triggers? So no triggers, can you have asthmatic attacks? From Muni Huru. And the fourth one, thank you for the presentation from Dr. Ben Mensah George. With Symbicort and the pediatric patient, could you throw more light on the dosage for the pediatric dosage? And then the last in that series is, please, is there the role of oral prednisolone in asthma management from Salma? So if you can take this and then we go ahead.
Okay, all right. So so the first one will be the one on the hygiene. I think Nicolina has raised their hand. But so the first one is a clean environment. So what they propose is that it's a theory that proposes that if you live in a too clean environment, you have a higher risk of developing asthma. And the reason why is that, you know, it goes back to basic immunology. So you have what we call T helper 1 and then T helper 2. So I'll go back to the pathophysiology slide. T helper 1 and T helper 2. And okay, not that this one. So the asthma, what is mainly involved is the T helper 2 pathway. Okay, so usually you have, okay, here. So you see Th2 cells, so T helper 2 cells. Okay, so you usually have T helper 1 and T helper 2. So T helper 2 is usually involved in more of allergic conditions and then parasitic infection. So once you're having a parasitic infection or allergic condition, you tend to have more of T helper 2 plays a role. T helper 1 is usually involved in more of infections, so bacterial infections, all those kind of infections you have. And usually when there's a fine balance between T helper 1 and T helper 2. So when you're born and you're not really exposed to a lot of infections, or you live in too much of a clean environment, because now you're living in a clean environment and you're not exposed to a lot of infections, your T helper 1 plays component becomes a bit underdeveloped, and then you kind of overdevelop the T helper 2 pathway. And this T helper 2 pathway is involved in a lot of allergic condition, which asthma is involved in. That is basically the thinking behind living in a clean environment, is that you develop the T helper 2 pathway, which is responsible for allergic conditions, etc., etc. while you underdevelop the T-helper-1 pathway. That's why they say living in a clean environment it's a risk of you developing asthma. Now, with the difference, the superiority between PMDI and the DPIs, okay, so your pressure meter dose inhaler and your dry powder inhaler. When it comes to efficacy, there's no difference in terms of efficacy, okay? What it all boils down is patient technique. So if the patient can use the dry powder inhaler very well, it's as efficacious as if they're using a pressure meter dose inhaler very well. So it all boils down to patient technique. The techniques vary between using a PMDI and a dry powdered inhaler. The technique vary. So really, you should really assess your patient technique to see which one they can really use well. Okay, but in terms of superiority, there's no difference. The only advantage that I kind of realized with the two is that with the PMDI, that's the pressure meter dose in here, the ones that's like Ventolin, you can connect it to a spacer. So if you have patients like children and they can't really coordinate the breathing and then the inhalation and then dispersing the drug, it's better you give them something they can use with an inhaler. It simplifies things for them. Elderly people find it difficult. When they're old, they have tremors and all those things. So trying to coordinate it is harder. So you want to give them with a spacer. And therefore, you can only use a PMDI with a spacer. That's basically the only advantage. But if they can use whichever one very well, it's not superior to the other one. Now, asthmatic attack without having triggers, I mean, it's not really. Usually there'll be something to trigger it. Unless you're having very poor control, you're not controlling the thing very well. But usually you have some form of a trigger. It may not be obvious. It may be obvious. So sometimes we give patients what we call a diary for them. If they start having an attack, they should kind of recall whatever they came into contact with to kind of help them figure out what their trigger is. But often you will have a trigger. Sometimes it's exercise, cold weather, even stress is a trigger for asthma. Even women who may be having their menses can have a trigger because of the hormonal imbalances. So usually there is a trigger. With the Symbicort dose, with the doses, like I said, this doesn't cover the pediatrics, but what I was just trying to drive at was that if this is for adults, so 12 and older, if you're using budesonide, which is Symbicort or Fortide, this is the dose of your low, medium, high, considered dose as low, medium, and high for adults. So if you look at 200 to 400, that's low for adults. But if you come to the pediatric population, 200 to 400, that's people less than 12 years old. 200, 400 is medium dose. So that's what I'll just alluding to, that if you're giving the steroids, really be careful on what pediatric, what population you're giving it to. Because adults it may consider low or medium, but in pediatric, what you're giving is considered high or medium. I don't know. And then the oral prednisolone, usually we reserve oral prednisolone as when you're getting towards step 5. Okay, so when you're getting towards step 5, you really are giving the oral prednisolone or then your anti-IgE medications, okay? But that's where oral prednisolone in chronic management. In the acute setting, anytime anybody comes with an acute exacerbation, you can give them oral steroids, prednisolone for a short period of time, like 4 days, 5 days, and then they stop. It's not something they have to be on for months for an acute exacerbation. Chronic management is only when you're getting towards step 5 that you consider oral prednisolone as part of their management. I don't know if I touched on everything.
Yeah, did you talk about the asthma attacks without triggers?
Yes, I did mention that.
Okay, yeah, then we're good to go. I think Nicolina's hand is up. I've asked you to unmute and ask your question, Nicolina. Hi, Nicole. Okay, she's gone. Then there's Moni Uru, so you can go ahead and ask your question. I see Nicolina is okay. Yeah, so go ahead.
I heard doctor make mention of using salbutamol is not that good in the treatment of asthma. I don't know whether I'm right. The use of it.
Okay.
But
Yeah.
where I worked at a polyclinic, Wallenbele, the last time, mostly what we have is the IV salbutamol at our pharmacy. So that's what we use. So I don't know whether it's safe.
You use IV salbutamol.
Yes.
Okay.
So
Okay. Pascal, would you want to address that?
Yeah, are you referring, I just want to clarify, referring to acute exacerbation, or you're talking about chronic management?
The chronic management.
Okay. So
actually it was a pregnant woman.
Interesting. Okay.
So Aston, you when the patient is going home, how does he take the IV home? That's what we are trying to. Because
actually,
chronic
when
management is going home.
she said she has an inhaler, but it was like it was finished or something like that, or something happened to it. But the husband brought her. She was having the attacks. And then the husband brought her to the facility. So we weren't having any inhaler or anything. The only medication that was available was the IV salbutamol.
Okay, Dr. Pascal.
That's interesting. This is the first time I come across using IV salbutamol in acute exacerbation. But it's not that you cannot use salbutamol. Salbutamol has a role. But what we are saying that the patient should not be dependent too much on salbutamol. That is where the problem lies. So if you look at this table, the lower one, track 2, you can see SABA, okay, as needed SABA. Okay, that's salbutamol. Not SABA doesn't stand for SABA, but short-acting beta agonist, which is salbutamol. So is that you are still giving your inhaled corticosteroids, okay, your ICS LABA, and when they're having symptoms, only when they're having symptoms, then you give the SABA. What we are just trying to explain is that they shouldn't be too dependent on the SABA, because if they're using it too much, it's a problem. It just shows that they're not tackling the inflammation. So if the patient has using it 2 canisters a month, you should be worried. That means you should increase your dose of your inhaled corticosteroids. What we are trying to recommend for all patients with asthma is for them to use an inhaler that has formoterol. Okay, so once they have formoterol, it simplifies things for them. Okay, so it just depends on what you have available. If you don't have medications that you can use that has formoterol, you are forced to use track 2. Okay, and it doesn't mean track 2 is not good, it's good, but just that if you are doing track 2, really be cautious on how much salbutamol they are using.
Yeah. Let's see. Nicolina's hand is up. Please go ahead. Kindly unmute yourself.
We don't know the
Hello, good evening.
Yeah, just kindly let Dr. Pascal finish up with the comment, and then you can come in, Nicolina.
Okay, sir.
All right, thank you.
Yeah, so IV salbutamol acutely, I don't know the efficacy or the detriment, but most often it's preferred that you nebulize your salbutamol. Okay, so there is a role for salbutamol, especially in the acute exacerbation. We use salbutamol in acute exacerbation, and then we use prednisolone or hydrocortisone as part of the acute exacerbation. Going home, when they're at home, we are just advocating that do not give them only salbutamol. They should have some form of inhaled corticosteroids. Try to avoid salbutamol tablet, asthma drain, and all those things. Acutely, they play a role in terms of nebulization, but not intravenously. So it just depends. So if you don't have the nasal salbutamol or an inhaler that has inhaled corticosteroid, really press upon your med people to try and just procure some. And Symbicort is on insurance. Fortide is on insurance. So it shouldn't be too difficult for patients to get them.
Yeah, thanks. I think it's good that some of these things are coming up. When I asked at the beginning about some of the medications, it just goes to explain that some of the things that we see still happen, and that's the essence of the webinars like this. And so don't feel shy. Please bring up. We are all learning. No one is perfect. We don't live in a perfect system. And so we can only make recommendations for your facility. Like Dr. Pascal mentioned, I think at the regional drugs store, they stock both the Symbicort inhalers, and then they have the Ventolin inhalers as well. But of course, the recommendation is that if you can do the budesonide formoterol, that's probably better. And so your facility should be able to make requests for those, and then we use rather than doing what may not help the patient, despite the fact that these are on insurance. So kindly talk to your medical doctor so that they can make these requests, and then they can have them sent over. Okay. Apologies. I think we've gone past the hour 4, but there are a couple of hands up. We'll try to address those ones so that then we can close off. So kindly give us some 10 more minutes on top of the hour to get this sorted out. It helps with rural practice. Otherwise, we may sit in the bigger cities and think that all is well. And sometimes even in the bigger cities, we go to some private practice and some of the things we do not help the patients. So it just helps all of us. So we crave your indulgence. Nicolina, please go ahead and ask your question. Yeah, you've muted yourself again. Nicolina, can you unmute yourself? I think she's probably having difficulties. Maybe we'll go to the next person.
Hello,
Emilia.
good evening. Good evening.
Yeah, go ahead.
Good evening, sir. Please, aside you enlightening us on the modernized way of the treatment and management of the asthma, do we have alternate? Because my mom said when she was young, she was having that asthmatic attack, but she was being treated in the form of herbal. So as right now she's aged, when the attack wants to appear, or maybe she's saying that she's coming to have the attack, she normally chew ginger with sugar, and then she'll be fine. So I just want you to enlighten me on the correct way of how she has to go about things, the way forward. Thank you.
Yeah, thank you. Dr. Pascal.
Okay, so I don't know the efficacy of the ginger and sugar in terms of managing asthma, but what I'll recommend, depending on what you have available at your end, if you have Symbicort or Fortide, which contains ICS formoterol, she can have that on standby. What you describe sounds like she doesn't have frequent symptoms of her asthma. It's as and when, so I'll put her around step 1 and step 2. And then she can use the inhaler anytime she's feeling like she's having the symptoms. Okay, so I would recommend that she have an inhaler on standby. If she can get Symbicort or Fortide, better. And then when she's having the symptoms, because it doesn't sound like she's having very frequent, she can use it as and when, PRN, that's step 1 or step 2. If it's more frequent, then you can just increase the frequency of her use. If she cannot have it, then she can get maybe an inhaler with like Seretide, which is the alternate other ICS LABA that's in Ghana. And then when she's having the attack, she uses that and then a salbutamol inhaler. But she shouldn't use the salbutamol inhaler alone. And also, before I end, people tend to give patients just prednisolone alone for a long period of time. Yes, it will help with the inflammation, but then don't forget the long-term effects of giving oral corticosteroids as well can be detrimental as well. So she should try and get an inhaler and use it as and when. If she's having ICS formoterol, put her on step 1 or 2 and use it. I don't know.
Great.
Yeah.
Yeah, Emilia, please go ahead. Hi, Emilia. I've asked you to unmute yourself. If you can unmute yourself and go ahead.
Hello.
Hi. Please go ahead with your question.
Yes, I was saying that I wanted to ask about the long use of the prednisolone because I know a client who is on that one. Then she was asked to switch to the inhaler. So I just wanted to ask about that one, but I've just realized that he has answered the other ladies this in question using that one too. So I'm okay.
Fantastic. Thank you. Hi, Nana, please go ahead.
Hello, Doc.
Hi.
Thank you very much for the opportunity. I'd like to ask Doc about the effect of the speed of administration of hydrocort on cardiac electric activities. Whether how slow or how fast we give hydrocort would cause any of the arrhythmias we know. And I'm asking this, we know hydrocort seems to be a first line in a lot of our facilities. And we recently had an incident where a gentleman died after receiving hydrocort when he presented with asthmatic symptoms. He was a known asthmatic. Now, the hospital explains the only drug they gave, which they gave within a matter of 2 minutes or less, was hydrocort. And it appeared difficult explaining how that led to the death. Some opinions have been expressed. And I just want to hear from you, from your side, internal medicine, whether we have some protocols on the speed with which hydrocort should be administered and whether they have any effect on arrhythmias. Thank you.
Thank you. Dr. Pascal.
Okay. For hydrocort, rarely does it. I mean, yes, it's been documented that it can cause cardiac problems like arrhythmias, like atrial fibrillation, and all those things. Okay, but the speed usually we give it as a bolus. Okay, if it's aminophylline that they were given, yes, that I'll be more worried than it is with hydrocortisone. Now, keep in mind that the person came in with an acute asthmatic attack. Most of the acute asthmatic attacks are usually avoidable. Asthma deaths are usually avoidable, as they say. But it depends on how bad the patient came in. You know, the severities in which someone's trying to say something. Okay, so
I think, yeah, you can go ahead.
Yeah, the severities in which the patients present, there's mild, moderate, and life-threatening. So it depends on how the patient came in. The patient's death may not necessarily have been due to the administration of the hydrocortisone, okay, because we give hydrocortisone as a bolus, but it hardly does it give any issues. If it's more of aminophylline, yes, that one has a lot of toxicity, and then it can cause cardiac arrhythmias, and that's why one of the reasons why they removed aminophylline from the guidelines. Okay, usually you should give hydrocortisone over. Some people say 3 minutes, 5 minutes, but then again, it's the giving it as a bolus. It should be a slow bolus. Within 2-3 minutes, the patient should get it. But even if you give it as a push, it shouldn't really cause arrhythmia. So it really depends on how bad the patient's asthmatic attack was that they came in, that may have led to their death, and not necessarily the hydrocortisone. Maybe the hydrocortisone didn't even kick in, and then they died from the asthma-related complications as well, because they can get cardiac arrest from hypoxia. Okay, the CO2 can cause type 2 respiratory failure as well. So they have a lot of things that can contribute to them passing on, and not necessarily the hydrocortisone. I've not come across hydrocortisone being given that will lead to someone passing away in an acute asthmatic attack. It's usually the severity that they came in with, or if you are using other drugs like aminophylline, that can lead to that. The other, I just lost my train of thought. The other thing is that apart from giving IV hydrocortisone, you can also give oral prednisolone. Okay, right now there's no difference in between there's the bioavailability between IV hydrocortisone and oral prednisolone is the same. So if the patient is talking and can swallow, you can give them oral prednisolone. Okay, if you are worried about the bolus causing problems, you can always give them oral prednisolone. It's the same efficacy, the same speed in which it will cause the broncho deal with the inflammation. But if the patient is very restless, can't talk, can't swallow, it's altered, then you want to give them a parenteral thing. But the parenteral shouldn't really cause much problem. So it could be the severity of the asthma in itself and not necessarily your hydrocortisone.
Great. I think I don't see any other hand up, and I'm sure we've learned a lot. In the chat box as well, we've been able to answer the questions that you've put up. A couple of those that you asked after have already been answered, like the IV salbutamol. I think Muni asked that and was answered, and then prednisolone after an acute attack. I think those are the two that we've done. So I just want to say a huge thank you to all of you for joining us for today. Sorry we went past the time, and it's because of the questions that we needed to address, and I'm sure they did help to explain a lot of things peculiar to our rural environment and what we should do and what we shouldn't do. I've learned a lot myself, and I'm sure most of us who have joined in today have learned a lot. If you do have some time next week, we have another legendary presentation on cardiac arrest with one of our colleagues, Dr. Eugene Ampofu. If you have time, kick in, same 3 p.m. to 4 p.m., same link, it never changes, same Zoom ID, same passcode. If you have an hour to spare to join us on a Thursday or on a Friday, please feel free. I've shared the links to accessing the recording. It will be put up on the YouTube channel, the slides as well, same. And you can like our Facebook and LinkedIn accounts, and you'll get the advertisement for this webness. But if you even forget, the same link you used to join today, anytime you remember on a Thursday or a Friday that you are free, just click on the same link, 3 p.m. to 4 p.m. and you'll be here. So thanks so much for joining us, and join me in saying a huge thank you to Dr. Pascal for making time to take us through asthma. And as I announced earlier, if you do want to join us in the presentation, they say knowledge is best when it's shared. And so you can get in touch and then we hook you up. We may not be able to financially reward you much, but we do have a 500 CD that we'll give to you for your airtime that you did spend with us. It's also our own way of helping to improve practice, because you may be the expert today, tomorrow you or your relative or a human being somewhere may need that expert guidance. And so if you don't take the one in the rural environment in a polyclinic to have to do either metered dose inhaler or get Symbicort or any of that, rather than do an IV salbutamol, it may not help the patient. And that human being, just like the good book says, what you do to the least of my brothers, you do unto me. So thanks for joining us. Thank you, Dr. Pascal, for a legendary job. God bless us all. Bye-bye.
Thank you.
Thanks.